Hi, and welcome to the June 2026 issue of iGIE. My name is Phillip G., editor for iGIE's section on historical considerations. Believing and investing in new technology requires great audacity and perseverance. In the early 1980s, the hottest innovation in endoscopy was ERCP, being rapidly popularized by giants in the field including Peter Cotton and others. Very few people took notice of another key innovation that was about to disrupt our field, endoscopic ultrasound, or EUS. In fact, for many leading endoscopists, the concept of EUS was simultaneously mysterious and intimidating. But there were some who had the foresight to realize the potential of EUS and had the courage and determination to develop and pioneer the technology. We are therefore excited to invite Dr. Michael Sivak to be our distinguished guest for the Historical Considerations section of iGIE to tell us about the beginnings of endoscopic ultrasonography. Dr. Sivak grew up in Erie, Pennsylvania, among a family of physicians. He received his medical degree from Hahnemann Medical College in Philadelphia and was an intern at Hammett Medical Center in his hometown of Erie. He then completed his residency and fellowship training at the Cleveland Clinic in Cleveland, Ohio, which was followed by 2 years as lieutenant commander in the United States Navy. He then spent his entire professional career in Cleveland, rising to become chair of gastroenterology at Cleveland Clinic from 1988 to 1993, before moving across town to become chief of gastroenterology at University Hospital's Case Western Medical Center from 1993 to 2005. Dr. Sivak is a world-renowned legend in the field of EUS, credited with popularizing the procedure and facilitating its adoption into standard advanced endoscopy practice, as well as influencing, training, and mentoring entire generations of endosonographers, many of whom have become leaders in some of the foremost institutions around the world. Over his illustrious career, Dr. Sivak also served as president of the FASGE from 1989 to 1990, as well as editor-in-chief of our flagship journal, GIE, from 1996 to 2004. Dr. Sivak retired from clinical practice in 2006. A testament to his lasting accomplishments, Dr. Sivak was awarded the ASGE's highest distinction, the Rudolf Schindler Award, in 1997, and was recently given the 2026 ASGE President's Award at DDW this past month in Chicago. I recently had the honor of being introduced to Dr. Sivak by Dr. Amitabh Chak, president of the ASGE and one of Dr. Sivak's mentees at Case Western Medical Center. This article and interview documents the history of endosonography as told by one of its most revered founding pioneers. Dr. Sivak, thank you so much for taking the time to do this interview. It's truly an honor and privilege. Tell us about your background and your family.
Well, thanks, Phil. That was a really nice introduction. Greatly appreciate it. Well, you pretty much summarized it. I came from a large family, grew up in Erie, Pennsylvania, born there, and many people in my family were physicians, so as I think I mentioned before, it was kind of like the family business. So, pretty much everything else in terms of dates and times and places is pretty accurate from your intro. I can't really tell you much more than that. So maybe we should just get right into EUS.
Sure. So tell me a little bit about gastroenterology at the time, actually, before we delve into EUS. Set me up in terms of who were your mentors at the time,
okay,
and how did this all, come about, in terms of your career?
Okay. I ended up at Cleveland Clinic for residency largely because my dad, who was an ophthalmologist, he went to lots of courses there and knew almost all of the ophthalmologists at the clinic. And he had high praise for the institution at that time. And I went there for about 6 weeks as a medical student and liked it. It seemed like there was many opportunities to do different things. Of course, it had a kind of different approach to practice, that is the specialty medicine approach. But nevertheless, I applied and they accepted me, and that's how I ended up at Cleveland Clinic. While there, I finally decided, it actually had decided a little earlier that gastroenterology was the thing. But at that time, we're talking 1972, was nothing like what it is today. In particular, it was a much smaller field, which is another way of saying there wasn't that much you could do for patients. And endoscopy, in particular, was very rudimentary. The fibroscope had been invented, but hadn't gone very far at the time. I did start with, my first procedure was with a fibroscope, but it was crude. I mean, really crude by modern standards. But then I think the thing that propelled us to where we are today, thinking about endoscopy, was the Japanese companies, mainly Olympus, and they, once upon a time, one day, a guy by the name of Hiroshi Ichikawa came down the hall, and he had an instrument called the GIF, or gastrointestinal fibroscope, and it was like the Cadillac of, it had four-way tip deflection, all kinds of things, and that was kind of the beginning. But this is another way of saying that I was lucky in the sense that I started when things were really about to take off. Of course, you didn't know that at the time.
Right.
But when I saw that instrument, I thought, gee, this could be something pretty big. So I kind of was in the right place at the right time. Cleveland Clinic was very much interested in what's new and how to develop it and how, especially that whatever is new could be applied ultimately to patient care. So they kind of were at the forefront of that sort of thinking. Anyway, again, up to that point, there wasn't much thought about treating GI bleeding. A big debate was the so-called, I forget what exactly, aggressive approach to the treatment of GI bleeding. One school of thought was you put the patient into bed and kept them perfectly still in the hope that it would stop, and oftentimes it did. But then the other approach was, let's get in there, find out what's going on, and see what we can do about it. And anyway, but none of the approaches to the treatment of bleeding, varices, et cetera, none of that had been thought about. So I came along when there was suddenly a lot of enthusiasm. The instruments got better almost by the month. There was something new. And that's pretty much the story. It brings us to where we are now.
Right. So, it's interesting how you mentioned it. It really has to do with being at the right place at the right time. But at the same time, I will also counter-argue that in life, one has to create their own luck to some degree as well. So you obviously put yourself in that position, too.
I agree with you. Well, you have to be insightful enough to recognize what might be about to happen and see whether you fit into that, whether you like it, whether you're good at it, etc. So yeah, it's kind of a combination of things. It isn't just purely luck, but luck plays a role. There's no doubt about it.
Absolutely. So at the time, you had Mr. Ichikawa had established a relationship with you, and I guess one day he showed you something new. Tell us a little bit about EUS.
Okay, well, there was a whole series of new, as you say, right, leading up to EUS. And I've been trying to place the date when he showed up with the first, he didn't actually show up with the EUS scope. He came to say that Olympus was working on some new technologies, and I couldn't take on everything, but he gave me a choice. And as I remember, enteroscopy was one possibility they were looking at, but the other was endoscopic ultrasound. And I don't know why, but I kind of rejected everything else on his list and zeroed right in on ultrasound. I sort of thought, wow, that's an interesting idea. I wonder if that's possible, that kind of thing. So I said, yeah, bring me whatever you have, this ultrasound thing. And a little while later, sure enough, an instrument showed up and with equipment.
And at the time, I understand it was yourself and the other being Dr. Lightdale in New York, who was invited to take part in the first endoscopic ultrasound procedure.
Hiroshi said to me at the time, this is going to be harder than you think. We are going to introduce it with two centers in the U.S.
Mm-hmm.
You and Charlie Lightdale, who was then at Sloan Kettering, if I remember correctly, and that would be the start. There would be, of course, others, and there may have been other people in the world. I'm sure there were in Europe, Asia, etc. But anyway, for the North America and maybe even the Western Hemisphere, it was me and Charlie. Why they had such confidence in us, I have no idea, except to say that maybe they weren't so sure this was going to be successful either. But anyway, a little while later, the instrument shows up.
I think they probably, they obviously chose well. I think they tagged the two people that they believed were open-minded enough to play around with what was otherwise a very crude and rudimentary instrument.
Right.
Tell us about this crude and rudimentary instrument, by the way.
Well, in the pictures that I sent you, we don't have a picture, I'm not sure anybody does, of the very, very first instrument.
Mm-hmm.
And it was crude, to say the least. For one thing, it was a fiber optic instrument. And it had a big contraption just below the control section of the instrument, a kind of heavy big box that housed the mechanical components. And it wasn't, it had a mirror, what was called an acoustic mirror at the distal tip, the business end of the scope, and that thing rotated, so it was a rotating acoustical, mechanical echo endoscope, something like that. Not only was it pretty heavy and fiber optic, but it had a limited field of view. I don't remember exactly, but it was less than 90-degree field of view. Mm-hmm. Maybe something on the order of 70, 75, 80, something like that. And the field of view was a little bit oblique from the long axis of the endoscope. So it was a little bit like using the duodenoscope. Other things that I thought were going to be difficult was the tip of the instrument, the distal tip, was rigid over a segment of probably more than a couple of inches. And that made it a little bit harder to pass the instrument. And of course, at that time, everybody had gone to visual watch where you're going instead of stuffing it in there with your finger approach to passing the instrument. And but that was not going to be possible with this instrument, so we retrogressed a little bit in that respect. And the next problem was acoustic coupling, mainly that you couldn't do ultrasound through air. So they solved the problem, or thought they solved the problem, by attaching a balloon to the end of the instrument. And the balloons were a nightmare. I mean, you just look sideways at the thing, it would tear. And it was a really difficult job to get that darn thing on the end of the instrument in the proper place, because the air insufflation channel was very close to the proximal end of the balloon, which, by the way, you secured in place with sutures. You had to tie sutures, and if you got it a little bit out of place, you found when you had the instrument in the patient, you couldn't insufflate any air because the balloon occluded the channel. So, and putting this thing on between cases or for a case was such a time-consuming problem. And just when you thought maybe you had the thing in place, you tore it. Not only that, but the balloon was supposed to inflate asymmetrically so that the bigger bulge in the balloon would be over the imaging section of the ultrasound. That was totally impossible to achieve that, as far as I could tell. The other thing, well, let me stick with the balloon a minute. So, if you're between cases and you're trying to put this thing on, and endoscopy units run by the clock, it just messed everything up. So, eventually, I found a man in the biomedical engineering department who was much more patient than I was, and he would place the balloon for us and haul the instrument back upstairs out of the basement and have it ready to go when I was ready to go. Now, how he did that, I don't know, and I'm not sure I ever wanted to know, but anyway, that's how we solved that problem. The other limitation on the scope, aside from being very heavy and awkward and so forth and so on, was the field of view. Initially, the very first one I had was only 180 degrees. Mm-hmm. So if you wanted to see something on the opposite 180 degrees, you had to rotate the thing. And if you had a kind of nice scanning plane, you thought you were where you wanted to be, and then you rotated it, sure enough, you weren't there anymore. So you had to kind of start over. The other thing is that you put the water in the balloon, and you had to do that without getting any bubbles in there. That's also a neat trick. But there was a lure lock fitting, this I recall was just above the motor housing, and you attached a syringe to that. And of course, they made it so that if you just attached the syringe, it would stick out at right angles to the instrument. And so as you move your hand back and forth between the insertion tube, you almost every time would move it up abruptly and break the syringe off. And of course, you say, well, just put a new one on. But now you had air in the system and pieces of the syringe were still attached. So the nurse would get a hemostat, take that off, put a new one on, and you kind of start over. Eventually, we figured out that, we'll use a piece of rubber tubing back to 1970 and the original endoscopes, and attach the syringe and so forth so that it would at least be not sticking out in the way of your hand. Anyway, that would be all the preparatory stuff before you even got the instrument in there and didn't have the faintest idea what the hell you were seeing with it. So yeah, it was a struggle, no doubt about it.
And I mean, how long would a procedure take if you were to factor everything in?
Depended entirely on how tough the patient was. And how much sedation you dared to use. And again, it depended on what you might want to look at. Now, Charlie Lightdale, being smarter than me, he decided we'll do esophageal cancer as our project. And that was pretty smart because it's more or less a straight shot and everything. And me, in my ignorance, decided, and this occurred to me when I first saw the thing, maybe we could find early stage pancreatic cancer. Wholly naive, that man. I mean, so even just getting there was part of the problem. When you got there, you didn't even know what the pancreas was supposed to look like at the beginning. So anyway, I took on pancreatic cancer, and Charlie did esophageal cancer.
Not to mention, all this was through a fiber optic scope, right?
Yes, yeah, you're looking at it, and the weight of this thing. I think, as I told you before,
right.
I never weighed it, but it had to add more than a pound or two to the weight of the instrument. So if you, in the course of a morning or something, did 2 or 3 cases, patients examined, pretty soon your arm was extremely tired, not to mention your neck and everything. So, yeah, it was a challenge physically, mentally, you name it.
And even the scope itself was bigger than other scopes of the day, right? It was a wider diameter as well.
The diameter, I think it was in the neighborhood of 12 or 13 millimeters, which at that time, the Olympus company had come out with the pediatric scopes, which everybody right away started using for adult endoscopy. I mean, they were marvelous instruments. And but yes, this thing was a step backwards in terms of diameter, weight, length, etc. So yeah, difficult.
So after you overcome all of these technical difficulties in getting started, how did you figure out what you were looking at?
Well, there were books written about ultrasonography, so I got stacks of books. I spent a lot of money on buying books, and you kind of visualized what the anatomy might be, and then a couple of things were important. It became pretty clear that you needed help, and so I went to the radiology department, and they of course had experts in ultrasound, and one of them agreed to help me. His name was, I haven't seen him in many years, Craig George, and he would come to the endoscopy unit and help me through various procedures. And I think I mentioned the second generation instrument, of which I gave you a picture, was this refrigerator size box thing on wheels, and it had a tiny screen. It looked like a television set from the 1950s or something. And the problem with that is, and it wasn't the best TV picture either. And the problem was, since it was so small, and Craig was a big guy, and he would get right up in front of this thing, and I couldn't see what the hell he was seeing because his head was in the way all the time. And so we kind of evolved. He would point this way or that way, and pretty soon I understood what he meant when he was moving his hand around, and I would try to maneuver as to whatever I thought he might be telling me. And then he would, if we got something that we wanted to see, he would punch the freeze button, duck out of the way, and I would say, "Oh yeah, okay," and we would go from there. The other thing that happened that I think was extremely helpful, and I don't know, I've forgotten the year of this. It was the World Congress of Gastroenterology, which in those days was a kind of big event. And it was in Stockholm, Sweden. And Olympus had organized it wasn't a symposium, it was like a get-together with the people that were doing ultrasound. Some guys from Germany, I've forgotten who the names, Japan, of course, and U.S. And we pretty much just talked about what the problems were and what to do about it. But at one point in the session I was chairing, we decided, let's start at the very beginning and try to at least make a list of the structures you should identify from various positions within the gut. So starting in the duodenum, and working backwards. That was extremely helpful. And from there, we really started to eventually, after, it must have been a year or more, started to get pretty decent images and could tell what we were looking at. By the way, I'll come back to this, but it occurred to me that as you're looking at the ultrasound, quote, texture of the pancreas, that if you could do a better analysis of the pattern of the image, that is the detail of the image, you might be able to spot little anomalies within the parenchyma of the pancreas. And I never really was able to pursue that very, very far, but we should return to that because I think that may become a reality in the not too distant future. Anyway, so after a while, it became with Craig George, it became so difficult to coordinate our schedules that after maybe 3 or 4 months, I was pretty much on my own again.
Mm-hmm. But by then, you guys had essentially developed the stationed approach to EUS examination.
Yes, that was what came out of the Stockholm meeting. Mm-hmm. That is, you got to get to this station, and you should look for XYZ 1, 2, 3, that sort of thing.
Right. Now, at the time, with EUS being so, I guess, in its infancy, was there a lot of skepticism in the beginning?
I think not so much skepticism as people just ignored all of this. Uh-huh. It was not worth being skeptical about.
I think I've heard that before from several other people that we've interviewed.
Yeah. Just, these guys are crazy. Let them be crazy. Don't worry about it.
So tell us a little bit about the subsequent improvements that Olympus made to the scope.
Oh, well, it eventually...
I mean, they obviously had to take your feedback.
Yes. Well, I mean, that was the main thing with... we had all kinds of meetings, and they would improve the instruments fairly rapidly. That is, a new one would come after 6 months even, maybe even sooner. And so the old one went out the door. They, I'm sure, took it apart, analyzed it, and they constantly asked questions. There was a fellow by the name of Dave Barlow who worked for Olympus in New York, and he would often come out, and they would have the Olympus notebook, about this big, and he would take page after page of notes, ask questions, and we would allow them to come in and watch us doing cases and so forth. And it would be very interesting if we could get their idea of how this went on. But of course, all of those guys that worked on it are gone, retired, who knows, except for Hiroshi. By the way, I did contact Hiroshi, but I haven't heard back from him. Asked him to fill in some of the blanks if he could, but maybe we'll hear from him. I don't know.
Sure.
But anyway, there was an awful lot of feedback. The instruments improved fairly rapidly. For example, the display console evolved from the refrigerator to a very nice, I think it was the 3rd generation one. Pretty sure you have pictures.
Yes, we do.
Of all the ones that we went through, I liked that one the best in terms of ergonomically and the way things were positioned on the panel and so forth. The size of the screen, the quality of the image, I thought that was like a giant leap forward. And of course, the instrument improved, and all of a sudden, it was a CCD instrument which solved all sorts of problems. The ability to control and insufflate the balloon, et cetera, all of that got better. Now, one thing I would point out here, and this was another sort of historical artifact. Olympus did not have early on the linear instruments, so that
correct.
We didn't even consider. Well, it was attempted. That is, what I'm talking about is fine needle aspiration or needle anything. It was attempted with the so-called sector scanning scope, but never, to the best of my knowledge, was successful and was abandoned pretty much immediately. But Pentax, and this is a whole other chapter story within the history, Pentax had gone with the linear array, which of course made it feasible for needle guidance under ultrasound. But it occurred to me, would you want to do that? And I thought to myself, holy smoke, this would entail a whole new learning curve on how to obtain and interpret the linear images. And Olympus didn't have it in any case. And so during this time, the linear instrument was also developing, although I think probably it was a little more delayed. Well, I'm not certain that's true, but it seemed to me a little more delayed than the development of the sector scanning instrument.
And I think along the way too, I think from the pictures that you showed us, the mechanical portion of the ultrasound scope also was moved away from the shaft, right?
Yes.
Reduced
Yes.
weight on the scope itself.
Yes, changed the balance of the instrument, and of course it got smaller and lighter, which was terrific.
Right.
But it did migrate around on the.
I saw that it shifted to the umbilicus, and then it shifted, and then it became that 2-cord setup that you see now.
Yes, pretty much, and all of that that evolved fairly rapidly over the course of a relatively few years.
Mm-hmm. Absolutely. Now, during those few years, I think those of you guys who were really the pioneers of EUS in the United States started a little group amongst yourselves called the EUS Users Group.
Right.
Tell me a little bit about starting this group and what you guys talked about and what you guys did.
Okay. Now, it's also, I've been trying like crazy to pinpoint when that first started. I think sometime between 85 and 90, say 87, 88. And there's a guy that worked at Olympus in the marketing sales department by the name of Mark Donahue. And I think he may have proposed it, although it was pretty indefinite or undefined when we started. But I think it was he, when we talked, that suggested, why don't we have a get-together? In other words, all the guys in the U.S., and it was only guys at the time, as I remember, that time it had the system. We would get together, and some of it may have been at existing meetings, DDW, for example. But so, of course, it was me and Charlie. But by this time, some other people had it. H. Worth Boyce in Tampa, who was an esophagus guy, he was working on it. Luke Teo, who I think was one of the very, very best at doing this, especially at the time. I think by this time he had come from Amsterdam to the U.S., so he was part of the original group, and there were 4 of us. And it was probably in year 2 or 3 or something like that that Rob Hawes joined. So the 5 of us were pretty much the core, and we would occasionally invite other people in, and just to join a meeting. And of course, there were usually no more than 2 or 3 people from Olympus, sometimes an engineer, but other times marketing people, and so forth and so on. And the purpose of the group was, number one, to discuss our mutual problems, that is, things, and then secondly would be to pass around ideas and solutions and so forth and so on. So it was an exchange of information. So learning how to interpret, how to obtain, obviously number one, but then secondly, how to interpret EUS images. That seemed to be our initial sort of challenge. But then over the course of time, we thought long and hard about how do you disseminate these ideas, because by this time we were pretty much believers. Not a lot of other people were, but we were pretty much committed to this. Mm-hmm. And so another third item on the list was, well, how do we let other people know about this? And then obviously the next obvious question was, how do we train other people to do EUS? And there were a lot of arguments about that, as I recall. We basically fell into 2 camps. One I always called the quick and dirty, since it wasn't my camp, was the let's have short sessions. Let's get people who are already good endoscopists and teach them how to do at least some of the basic things, and hopefully then they get started on their own. That was one. And the other was, nope, this is hard enough. You got to take somebody at least 6 months, maybe a full year, to fully develop and make them competent at this. Of course, that approach, the downside was, well, there's only 5 of us. If we each took one person per year, it would take 100 years before this ever became widely disseminated. But anyway, I don't think we ever solved that. We did run a few actual symposia tacked on to other major meetings. We did evolve an annual sort of ultrasound meeting, which went on for a number of years, at least a decade or more, and we all participated in that. We did do some basic research, mostly on interpretation of images. I remember one on smooth muscle tumors. That is, we wanted to see what would be the characteristics of a benign as opposed to a malignant tumor, and we did a study on that, which I thought was actually halfway decent. So there was a little bit of that, but it became clear after a little while that we were not going to solve all these problems with our little group. So we put together an idea called the American Endosonography Club, and we even worked up letterheads and other sorts of things. We elected officers, basically us. And you might think, well, that's very ambitious to establish a whole new endoscopy society. But the actual plan was to embarrass the ASGE into doing more to promote EUS, which, in fact, they did. They set up a committee, which essentially was the American Endosonography Club, and of course, that evolved through various and different things. But the whole purpose of that, as I remember it, was mainly to prod the ASGE into doing more with the U.S. So yeah, I think I forget how long I've got minutes. I used to do the minutes for the meetings and the agendas, and I forget exactly when we stopped. But Olympus decided that things we probably had progressed as far as we were ever going to go with a small group of endosonographers. So it ended. I think the last meeting was in Santa Fe, New Mexico, but we just kind of stopped it one day.
And by then, I think enough people were starting to learn EUS.
Oh yeah, it sure. At DDW and towards the mid to late 90s, it was a big component of everything. So yeah, it was off and rolling, and not much else we could contribute at that point.
Do you think most people learned it from the quick and dirty way in hindsight, or do you think a lot of people learned it the more formal fellowship style way?
Well, the other thing that happened with advanced fellowships is just about everybody has one nowadays.
Right.
So I would say that the best trained people are the products of those programs. But early on, it was probably some combination. You got whatever formal training you could get, sometimes extensive and really good, other times a little bit less, and you kind of stumbled your way along. So it's hard to know then what the ultimate product was. That is, at the patient interface, what the level of expertise was overall for EUS. But nevertheless, it did progress.
Absolutely. And I would imagine it took a lot of investment and a lot of belief, basically, by the device manufacturers to commit to this technology, especially in the early days. At what point do you think device companies like Olympus or Pentax became convinced that EUS was here to stay?
Well, that's an interesting story also, another sort of sub-story in the history era. Early on, the head of the medical instrument division at Olympus was a guy by the name of Mr. Kawahara. He, in the way I knew him, was an old-fashioned, if you will, gentleman, and his attitude was, I think, I'm paraphrasing now, so but I think he felt that we have a mission over and above making money for the company. In other words, and he pretty much would listen to the doctors. And so there is a story, I don't know if this is true or not, but somebody asked him once, why are you continuing to do this since it's, and we're probably, I don't know, a decade into the thing, because it's not absolutely clear that this is ever going to amount to anything. And apparently and I did not hear this, but other people have quoted it to me, but he said, because the doctors want it, and in other words, belied some faith in the foresight, the prescience of the physicians who were using it, but it also showed that he thought that his job was to try to build instruments that would do what the doctors want, and I thought that was something unusual. But anyway, I credit him with the perseverance. We did oftentimes ask, like Mr. Donahue at Olympus, are you guys making any money on these things? And he said, absolutely not. This is a loss leader. I mean, and I'm sure over the course of time, yes, it probably undoubtedly became profitable. But nevertheless, early on, it was a big time investment, lots of personnel, money, et cetera, in developing this thing. And he never did answer the question, by the way, Donahue, have you ever made any money on this? But at least through the first decade or more, it was a loss leader, no doubt about it.
I'm sure for institutions as well, right?
Well, that was the other thing. After it became an item that you had to purchase, mind you,
right.
Nobody in the users group early on was purchasing these things. But the problem was, of course, it was early stage instruments, and you broke them all the time. I mean, and a repair bill on an echo endoscope could be substantial. Not only that, but the initial price was, I don't remember exactly, but it was much, much more than a standard endoscope. So when you go to your administrator and say, hey, we want to buy, and it's $100,000, whereas, and he'd say, well, what do you charge for this? And, well, nothing right now. I mean, you can see where this conversation would go. Anyway, yeah, it was interesting.
Yeah, but thankfully, I think a lot of the institutions that you worked for, they seemed that they were supportive of this. And
yeah, well, at the time, the Cleveland Clinic was willing to invest time and, of course, money, since if you were working on EUS, you weren't doing colonoscopies or something. They had an abiding interest in developing new technology. Of course, down the road, it would pay off for them. But, of course, there were probably some that just didn't amount to anything, too. So,
right.
But, yes, I was as again, fortuitous, lucky, in an institution that wanted to invest the time and effort in these sorts of things.
I'm sure there was a collective sigh of relief from both the Olympus and the device manufacturer side, as well as from you guys' side, when it became clear that EUS was here to stay.
Yes, it wasn't like a sudden, all of a sudden happened. It just gradually developed that more and more EUS was actually insinuating itself into clinical practice. For example, esophageal cancer, all of a sudden, the thoracic surgeons that operated on these poor people thought that, and I'm not sure why, but they began to think that a careful staging of this tumor is helpful, could be helpful, would be helpful at the time of surgery. And so suddenly, everybody that was facing this disease, pretty much all of them were referred to us for staging the esophageal tumor. And it turned out, yes, we were actually pretty good at that. That is to say, we were better than the CT scan of the day in picking out lymph nodes and other kinds of things that might be important.
Was the same true for the pancreas as well?
No. As you know, pancreatic cancer is a bad disease.
Right.
And the only thing that we got good at that resulted in referrals was fine needle aspirations of the tumors. So the surgeons would like incontrovertible evidence that, yes, that's what you're dealing with here. But did we early on save anybody? I doubt it. Now, I mentioned when we started that this whole idea about looking at the texture of the ultrasound image.
Right.
I don't know if texture is the right word. But at DDW, they inaugurated a named lecture in my name. And one of my students, Mimi Canto, she did the inaugural Sivak lecture. And one of the things she talked about was people at high risk for pancreatic cancer, usually with genetic disorders that I don't even know anything about anymore. You could identify people at high risk, and sure enough, she is actually, I think, safe to say, saved a number of people, or at least markedly prolonged their lives because they did EUS with the foreknowledge that, yes, there's a very high risk likelihood you're going to find something. The other thing she said, and I think this may be key, is that you with your eyes can't look at these images of the pancreas and pick out some subtle, tiny anomaly or something. But we now have artificial intelligence, and she and her colleagues are thinking, yeah, maybe that would be the thing, and that would be really a leap forward. And I'm just very happy. I'm so happy that one of my students has been able to do this. When I first saw the thing, I thought, I wonder if you could do this. And I never did. But it is super gratifying to know one of my students actually may be doing this, is doing this.
Absolutely. And as we saw from your, as you relayed from your article, she was your only student that did 2 years with you. So maybe that had something to do with it.
She's super educated. Yeah, way more education than is necessary. Yes, she is.
Very good, very good. You know, it's very interesting when you look back on a career like yours that, you know, a lot of your contemporaries were very much intimidated by EUS when it first came out. But you clearly saw something different, you know. So tell us a little bit, in terms of inspiring the future generations. Like what is your mindset? Like, how is it that you saw promise when others did not?
Well, first of all, remember the mindset of the times. Endoscopy was taken off. It was like every 6-12 months there was a new great thing. We had PEG, we had all sorts of treatments for bleeding. ERCP had gone to therapy. We were doing more. We probably were altering the course of disease. Yes, not as much as we thought we were, but some, for sure. So it was a very, very enthusiastic time. And again, fortuitous, lucky, I was in a place then when I could do this for all sorts of different reasons. But the other thing is, Heraclitus said something to the effect that character is destiny. So it's just the nature of the way I approach things. So a lot of times it just comes down to a question that you ask yourself, I wonder if I could do this. Mm-hmm. And it looks hard, maybe even a little dumb, but I wonder if this could be done. Do you know what I mean?
Yeah.
I don't know how else. I don't know how else to explain it. So And certainly these procedures early on, in particular, were exhausting. You put in an hour and you'd say to yourself, what the hell do we have to show for this? And not much. But it was interesting. It's certainly the idea that you could marry the endoscopy with ultrasound. That's a pretty radical idea. And so for some reason or other, just kept going. Never said to myself, why don't you take up enteroscopy or something else, just didn't. We kept going. And of course, having the users group, somebody got a little discouraged. There was, everybody else was cheering for the team and so forth and so on. And Olympus was still there. Said, don't worry, we'll fix the instrument. You'll get another one. Don't worry. And again,
it's a very unique combination of events. It's almost like the EUS Users Group was actually the EUS Believers Group.
It was. There's no doubt. There's no doubt about it. I don't think anybody ever said, "Why the hell are we doing this? Shouldn't we do something more constructive?" I don't think that ever came up.
That probably came from other people in the field, but not from within the group, of course.
Well, yes, amongst your colleagues,
right?
Especially the hepatology people would think, "Whoa, these guys are out of their mind," But anyway, there you are.
Little did they foresee the rise of endohepatology, which is one of the newer fields within endoscopy.
See, you just left me behind there. It's been such a long time.
The other thing that I would say is you touched upon this briefly with Mimi Canto giving her lecture, but you really leave behind an incredible legacy of endoscopists that you have mentored and trained over the years. Tell us a little bit about advanced endoscopy training and what it takes to be a successful mentor.
Yes. When I started, there was no such thing. I should mention that the other lucky thing that happened to me is I did acquire a mentor. This is when I was in fellowship at Cleveland Clinic, and that was Ben Sullivan, Benjamin Hardy Sullivan Jr., former Army colonel, went to WW2 on the Queen Mary, et cetera, et cetera. It was kind of the old conservative guy with the young, crazy, radical, young guy, doesn't know how dangerous he could be, that sort of thing. Anyway, so there was that, and we spent a lot of time doing things, that is endoscopy things. And so, in effect, even though it wasn't called as such, that was almost like a special training thing within gastroenterology. But sometime in the 80s, early 80s, I think, I went to see Peter Cotton. He actually invited me to one of his so-called courses, which was basically a small group of guys, a television set, a little clip-on camera thing, and they sat there watching procedures, and then you discussed the whole thing and so on. And he had 3 graduate gastroenterologists working for him, not exactly working, but they were there to learn to do advanced procedures, which at the time was essentially ERCP. But anyway, I said to myself, wow, this is an interesting concept. And so when I got back home, I decided, why don't we formalize this thing? In other words, a specific length of time with written down definite objectives, with an interview process, with interim evaluations, try to select the best possible candidate. The criteria were very specific. I wanted not only well-trained people, but those that would do the same thing over again. In other words, an academic type that would establish a similar program to include research, special education, essentially doing the same thing I was doing. So we set this all up. It was all formalized, written down, et cetera, et cetera. We put out some sort of notice. I don't even remember what it was, but we got applications. I actually interviewed people. I would have a group of 2 or 3 other people with me. We'd look at applications. We'd winnow it down to 2 or 3 or so. We would actually have them come to Cleveland for an interview. And we would select somebody. And there was about, I don't know, it was a little under 20 individuals over the years that went through the program. And of course, many of them, not all, but many of them fulfilled the ideals of the program. They went on to do the same thing, but only better. So yeah, that's pretty much how that started. Other people did have kind of programs, but I don't think anything was as structured, thought out, formalized, a plan, objectives, et cetera, than we did.
So in other words, I think the recipe, the secret sauce, if you will, was basically selecting candidates who were like-minded as you, who basically would then not only take the training and run, but take the training and then pass it forward by establishing their own programs. Basically, you were training those people who you foresaw would be the leaders.
Yes, exactly. They were supposed to go out. Now, how often did that work? Not always. I would say that a little more than half of them pretty much did that. Mimi Canto would be a prime example. Amitabh Chak wasn't a member of the program, but he was young when I started as chief at Case Western. And so, yeah, we did a lot of talking. I tried my best to organize his duties and so forth that he could develop in these directions. There were several other, Ashley Foe, Gerard Eisenberg, that went through the program, but they were all doing pretty much what I set out to do. Pat Fow up in Wisconsin, and so on. Oh, Jacques Van Dam. Oh, yeah, Jacques. A prime example. They went out and they did these things. So of all the things I did, I think that I'm most proud of, and probably the only thing I miss about practicing gastroenterology.
Absolutely. Especially after such an illustrious career. So it's come full circle here. So you retired 20 years ago in 2006. And you're, to my understanding, one of very few people who were able to just kind of step away, really at kind of the pinnacle of your career. Was that easy to do? And what have you been up to since?
Well, the question easy. It did take me a little while. Not necessarily a little while. I kind of knew what I was going to do, but I didn't just suddenly walk out the door. I stepped down as chief. I then and they owed me a sabbatical year, and I figured I'm going to get as much out of them as I can. So instead of studying medicine or anything, I went to astronomy school. I took astronomy courses.
Okay.
But anyway, that's an interesting story. I was by far the oldest person in the room, including the teacher. And they would look out of the corner of their eye at me and wonder, what the hell, who is this? And but I was the best student in the class. I came prepared. I was right there on time. I took notes. I aced every test, got A's in the course, answered questions, participated. In other words, I did my level best to make all them other young student types look bad, as bad as I could. Anyway, so I did that, and then I did piecework at the VA for a while, but I always knew I was just going to stop. And so you asked, was that difficult? And I can tell you, no, not in the least. Of course, I had thought about it a while, and I had a plan. But you have to understand, when I started in medicine, so I got my license in 1970. So I was an actual physician. I could actually take care of patients. It was my responsibility, etc. the practice of medicine was totally different.
Right.
You cannot, as this doesn't know aspersions on you, but you can't possibly appreciate
Right.
the sense of the difference, because you'd had to be there and understand what it was.
Right.
And so there's all of that, and that means when I came down to 20 years ago, it seemed to me to be becoming a little bit onerous. So that was part of the factor. I feel for physicians a lot. I watch my own long list of doctors, and you can see them being ground down. You can see sometimes their attitude towards the patient is shifted from, I really care, I'm going to do the very best I can for this patient, to, well, I got to punch the clock. The RVUs say I got to do this, that. I'm in the back of their mind. They got this script from the RVUs about how we're going to do this, and you can see some of them fight, and some of them acquiesce. And of course, I go around trying to find ones that are still fighting, and they're fighting mostly their own system. They work for some corporation or something like that. And so with that in mind, and secondly, I've pretty much done everything I could think to do. I wasn't chief anymore, so I had far less influence. It wasn't hard. Plus, there were so many things. I had been working so hard over the years, so many things that I wanted to do, just personal things, that I figured, hell with it. And so I had dinner at DDW with Thomas Roche from Germany, an old friend. And he asked me, he said, it looked to me like this was very deliberate. And I said, yeah, it's absolutely deliberate. And I gave him the football analogy of, I don't know, you don't remember, you weren't even born. There's a running back for the Cleveland Browns by the name of Jim Brown, and he was really, really something. And in those days, the Browns won the NFL championship. Largely because of him, Otto Graham, Lou Groza, those guys. You have no idea who these people are. But anyway, when he retired, he just did it. He didn't do sportscasting. He didn't do coaching. He just walked away from football. And he walked away still in the record books, So I figured that's the way to do it. Just walk away from it. Anyway, wasn't that hard.
Good. And obviously, it seems like you have plenty of other hobbies and passions. Tell us a little bit about what else. What are your hobbies and passions?
Well, again, going back to, I wonder if I could do that sort of idea or mindset. I have a real nifty telescope. I love astronomy since the age of 13. When I was 13, I painted houses one summer in order to get money for a Edmund Scientific reflecting 6-inch reflector telescope. So there's that. I actually like, I'm a bibliophile. I'm like a book snob. I think paperbacks are trashy, no matter how good it is. So I have all hardback books. I've collected books since I was a teenager. The number in the thousands. What you see behind me is less than half of it.
Wow.
I read 4 or 5 books at a time. I'm working through the letters of Seneca's letters on ethics now. I'm reading Thucydides. I'm reading Julia Dent Grant's memoirs, just all kinds of stuff. So I do that. And lastly, I've gone into microscopy. I have a nifty microscope, and I try to make slides. So in the late 1800s, early part of the 20th century, microscopy was coming into its own, and a lot of it was, how do we put things on these slides so we can study them? But now, of course, it's all automated, and this is an old-fashioned bygone art. But I still try to do that. And I collect old texts from early 20th century on techniques for mounting specimens and so forth and so on. So
Interesting.
I like to do that. And lastly, I am a professional grandparent. I have two grandsons here, just graduated from 8th grade. So I spend time giving them whatever they want, pretty much. And so we don't see them that often, but we have a lot of fun with them. And that's it. That's
quite a bit. That's quite a bit. And so, you actually touched upon a couple of things I want to ask you as we close out this interview. First of all, it's been truly a pleasure, and it's a wonderful and deeply insightful interview, and I want to thank you for this.
Thank you.
But for people who really want to, you bring up the doctor nowadays of being ground down and wanting to fight the fight. For those who still want to fight the fight, and also for future generations like your grandkids, what advice do you have for them, for future generations who want to make something of themselves like you have, or who want to be successful as you've been?
Yeah.
What advice do you have for them?
Well, first of all, going back to Heraclitus, character is destiny. So character is not, you are born with it, but you develop it over the course of time.
Mm-hmm.
So if you want to be successful, you've got to really know yourself and think about that, and think about how you make decisions. As I said, I read a lot of Stoic philosophy, which is nothing what people's impression of it is. But anyway, so you do make your own character. But again, Heraclitus' character is destiny. So there's that. To have a professionally successful career, I don't know if I ever truly, deeply liked the practice of medicine, except with Ben Sullivan and so forth, I liked endoscopy. So finding something you like, which of course you have to balance with, is this sensible? Am I going to make a living? Can I have a family with this career? So there's that. And then to be a little bit lucky, and mentorship is very important. I had Ben Sullivan to kind of guide you along the way, all of those things. And but when we come to physicians, as I said, in 1970, it was just the battle against disease. We got to cure somebody here somewhere. We got to do this. And your sense that when you took on a patient, you had a terrible responsibility, and you had to be at your best all the time. And there was nobody looking over your shoulder counting RVUs and so forth and so on. That was just unnecessary. Now, of course, the insurance and so forth and so on was just paying and didn't create all the problems with the cost of medical care and so on and so forth. But nevertheless, you could do that. So now, if somebody asked me, should I go into medicine, I would say, well, think really hard on it, and understand that it isn't just anymore the fighting to save somebody to make their life better. It isn't just acquiring knowledge, working really, really hard so you can do that. You have all of these other societal business things hanging over your head that you've got to kind of load on your back and carry with you. So my first thing would be to say, be sure you understand that. Then there is the final reward for doing it. My daughter is a doctor. Maybe I shouldn't tell you this, but my daughter is an oculoplastic surgeon. One time when she was in residency, and I think this was at the VA, I don't remember exactly, but she said she operated on a vet, and I think it was something simple like cataracts, which would have been the usual thing for a resident maybe. And she said after he could see, he thanked me and he kissed my hand. And so if you can do that, that's the reason to do it. Sorry, cut that part out.
I think that's perfect. That's a great way to end the interview.
Okay.
Well, thank you so much. Really, it's truly been an honor and a blessing to have been able to meet you and have this interview with you. We look forward to seeing this in its final form, published on iGIE.
Okay.
And again, thank you so much, Dr. Sivak. It's really been an honor.
Would you want to do another one?
Sure, anytime.
The video endoscope?
Sure, anytime.
You serious?
Anytime.